30-year-old male presented to ER with complaints of fever since 1 week, loose stools and generalized tiredness since 4 days. On initial 10-second assessment, airway is patent, no pooling of secretions. Breathing, respiratory rate is 16 per minute, saturation 99% in room air, air entry bilaterally equal. Coming to circulation, BP is 110/70 millimeters of mercury, pulse rate is 86 per minute, all peripheral pulsations are equally felt. Coming to disability, GCS 15/15, bilateral pupils equal and reacting to light. Coming to exposure, temperature is 100.6 degree Fahrenheit, GRBS was 100 milligram per deciliter. We have given an injection PCM 1 gram IV stat at this point. Adjuncts to primary survey, we had done a CBC CRP point of care showing WBC count of 3800, hemoglobin 10.4 and platelets of 96,000 and CRP of 88. And VBG showing pH of 7.442, potassium 3.4, sodium 125.
What is the WBC count?
3800.
Okay. What are the bacterial infection will have normal WBC count?
Salmonella, leukopenia.
Typhoid is the only known infection in our area which can produce normal count. Like leptospira sometimes can have, this rickettsial sometimes can have. But the most common infection in our area, normal WBC or slightly leukopenia is typhoid.
Chloride of 92, lactate 1.3, creatine 1.19 and bicarbonate of 23.9. Coming to secondary survey, a 30-year-old male with no known comorbidities presented to ER with complaints of fever since 1 week. Fever was mild initially, subsiding on antipyretics and then recur. Patient also had complaints of loose stools, 7 to 8 episodes per day since last 4 days.
What are the fever episodes associated with loose stools? Fever conditions, common infections.
Enteric fever.
And which type of enteric fever?
Paratyphy.
Paratyphy. Then common infections in our area which is associated with diarrhea. One is typhoid. Then bacterial gastroenteritis, E. coli, Klebsiella, all these things. Then amoebiasis normally there is a different category of infection. They may not have high degree fever. They can have fever, but this type of fevers are not very common. Then hepatitis. Hepatitis is the most common condition. Hepatitis A. It is very common in our area. Okay. Dengue is one condition where you can get diarrhea. Many patients with dengue is having diarrhea.
Patient also had complaints of loose stools, 7 to 8 episodes per day since last 4 days. No history of blood in stools. He also had.
What are the electrolyte abnormalities you see in diarrhea? ABG abnormalities, electrolyte.
Bicarbonates can be lost.
Okay.
Potassium, chloride, hypochloremic.
Potassium, is it low in diarrhea? It is not very common. Severe diarrhea like cholera and all you can get. Routinely, potassium loss is less in diarrhea than vomiting. Okay.
He also had complaints of generalized mild abdominal pain which was dull aching and non-radiating type. There were no aggravating or relieving factors. There is no history of any cough, shortness of breath, dysuria, rashes.
Is there in blood in stools?
No history of blood in stools. Rashes or altered behavior. He was evaluated outside and Vidal was done from outside which showed.
Why you are asking altered behavior in this patient, diarrhea patient?
Any CNS encephalopathy.
Enteric encephalopathy. Okay then. Only enteric encephalopathy. Electrolyte. Which electrolyte imbalance can produce altered behavior in diarrhea? Is it common? You are seeing a lot of diarrhea. It is not very common. Diarrhea as such will not produce electrolyte imbalance, and that produces encephalopathy is very, very rare. Toxic encephalopathy can occur sometimes. Patient who is having chronic liver disease can have some type of altered behavior. Otherwise, the diarrhea as such will not produce any type of encephalopathy. Atypical pneumonia, diarrhea is very, very minimal, not like this. They have loose stools, but they will not have this type of diarrhea.
He was evaluated outside and VIDAR was done from outside, showing Salmonella typhi H more than 640, O and paratyphi A, H, DH are less than 80.
What is the difference between O and H?
O is more
Capsulated.
Which is more important?
O is more.
Remote infection. Here, which one is
H
positive?
was positive.
H is positive. So we cannot completely depend on this investigation. So what do you do to diagnose it?
Blood cultures can be taken.
One is blood culture. Second thing, can you do another investigation of VIDAR? So if there is an increase in the titers of or titer, then it is diagnostic. Or sudden surge of the titer within 48 hours to 4-fold or 6-fold, then that is also diagnostic. Here it is only H is positive. Okay.
On examination, patient is conscious oriented, obeying commands.
What is anamnestic reaction?
O, H. I mean,
Anamnestic reaction is more common in which, O or H?
H.
H. So some other infection produces high titers, or previous infection producing high titers. Okay.
There is no pallor, ictercyanosis, clubbing or lymphadenopathy. Per abdomen, soft, non-tender, bowel sounds were heard. Respiratory system, normal vesicular breath sounds, no added
Is
sounds.
the patient complaining about abdominal pain? What investigation you do?
USG abdomen was done.
X-ray is very important. UST can be done. Erect abdomen X-ray is the most important investigation, which can be done in ER. You can do ask for CT scan if available, but erect abdomen is one of the most important investigation in this case. Why it is like that?
To rule out perforation.
Perforation. Okay, gas under diaphragm. Okay. They will not produce. They will not have intestinal obstruction. They have intestinal perforation. Okay.
CVS S1 S2 normally heard, no murmurs. CNS, no focal neurological deficits. We had done a blood investigation.
What are the CNS abnormalities of typhoid?
Muttering.
What is it?
Picking clothes.
Picking clothes. Okay. So that is the most important and most early finding of encephalopathy. Muttering delirium.
Muttering delirium. Blood investigations showing total count of 4,000 and 0 eosinophils.
Can you get a high WBC count in enteric fever?
When there is peritonitis.
Peritonitis. Okay.
Urea was 20.5, creatine 1.7, and SGOT was 90.
Is creatine normal here for this age?
Slightly higher.
Slightly high. So what are the reasons for this? Enteric fever as such will not produce elevation in creatinine. Most of the cases, if you see follow up the cases, you don't see much of elevation in creatinine in patients. So what may be the reason here?
Renal causes.
So dehydration is the most important cause which can produce. So how do you know that it is dehydration? Urea may be very high. Then other features? Clinically dehydration. Then BBG, what you are looking at? Lactate. Is the lactate is high here?
No, lactate was 1.3.
1.3. Slightly higher, but it is normal. Sodium?
Sodium 125.
Okay, that is also low. Okay. Can it happen like that? A dehydrated patient sodium can be low?
Hypovolemic hyponatremia.
Hypovolemic hyponatremia. Patient is not taking salt, losing a lot of salt, both can produce. Okay.
And SGOT was 90, SGPT 56.6, and alkaline phosphatase was 95. Lab sodium was 124.8 and potassium 3.5, and CRP was 177 on the day of admission.
Okay, is he alcoholic?
No, not an alcohol.
SGOT is high than
SGOT.
SGPT. Is it very common in infections, SGOT higher than SGPT? Normally in infectious hepatitis, what is the usual pattern, what you have seen? SGPT is always higher than SGOT. But patients who is taking alcohol, SGOT will be slightly higher than SGPT. Why it is like that? Why SGOT is elevated? It is not SGOT is elevated, SGPT is not produced. That is the reason. Alcohol can reduce the production of SGPT. That is the reason. Okay. So you have to ask the history of alcohol in this patient.
We had done a USG abdomen and pelvis, which showed borderline splenomegaly. And blood culture was positive from gram-negative bacilli. And he had fever spikes and loose stools during the course of
Procalcitonin? What is the procalcitonin?
Procal was 50.
50.
Then patient was started on Piptas, and now patient is not having any fever spikes or loose stools, and we were given symptomatic management for loose stools, Ridotril and IV fluids 30 ml per kg.
What is a Ridotril?
Resicadotril,
What is the action of that drug?
antisecretory.
Antisecretory. Huh?
Encephalitis.
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 Okay, reduction in the gastric secretion. Okay. Can you give loperamide in this patient?
No,
Why?
means if there is no, there will be collection and it can be infected.
Collection means what?
Abscess.
Huh? Toxic megacolon means what? What is that? When you use this type of drugs, patient can have stasis of your stool, which can be there in the intestine. That can sometimes produce more infection, more absorption. Then intestine can get dilated. So that should be avoided. You should never give loperamide or Lomotil in an infective diarrhea. Other types of diarrheas you can give. Okay.
Now patient is asymptomatic, planning for discharge.
Where will you use steroids in enteric fever?
When there is encephalopathy.
What is the dose of steroid?
3 mg per kg.
3 mg
Per kg.
per kg. So it will become how much? Which steroid you give?
Dex.
Dexamethasone. How it is different from hydrocortisone? Dexamethasone. Why you prefer dexamethasone in enteric encephalitis? Why? Can we give hydrocortisone? Yes or no? Yes or no? Can you give hydrocortisone in enteric encephalitis or common meningitis? Meningitis also we give first dose we give dexamethasone in encapsulated organism. Why it is like that? What is the advantage of dexamethasone over hydrocortisone? Blood-brain barrier, that is the answer. It crosses the blood-brain barrier. This is one of the most important drug, steroid, which crosses the blood-brain barrier. So we give all types of neurological condition, we give dexamethasone. Is there any advantage over hydrocortisone in encephalitis, meningitis? Is it mineralocorticoid action is there or not? It is less comparing with hydrocortisone. If you give hydrocortisone or methylprednisolone, fluid retention is more. Okay. In encephalitis, meningitis, we don't want further fluid accumulation. So we don't try all these things. Dexamethasone is cheap and best, and it crosses the blood-brain barrier. There is no fluid retention. There are a lot of advantages. There is no major disadvantage. Okay. Which condition hydrocortisone is better than dexamethasone? Sepsis with shock. In shock conditions where the shock is associated, then hydrocortisone or methylprednisolone will be a better choice than dexamethasone. That also got some mineralocorticoid action, but not like other drugs. Okay. Now, what happened to this patient? Antibiotic? You continued antibiotic or de-escalated? It is de-escalated. What is de-escalation? De-escalation and escalation means what in antibiotics? What is that? Recent sepsis bundle guidelines. We have to start empirical antibiotic in 1 hour, first 1 hour. So it is not always true that you are starting antibiotic and continue that antibiotic continuously for many days. You can de-escalate. Suppose you find out that this infection is susceptible to a lower antibiotic, you can de-escalate. Or sometimes you will have to escalate. Okay, so here we are de-escalated to ceftriaxone. Is there any difference between magnesis, ceftarazones? Is there any difference between these two? Should we de-escalate this antibiotic? Yes or no? Since you already de-escalated, I am not telling anything. But is there any difference? There is no difference. There is no need to de-escalate because both are in same category. You no need to de-escalate it at all. Okay. So you can continue the drug same like that. How long you have to continue?
10 days.
10 days. 7 days is enough. Most of the enteric fevers will subside within 7 days. Some patients may require longer treatment. What subset of patients?
Chronic carriers.
Carrier. What type of profession?
Cooking. Chef.
Chefs, they require maybe longer treatment. They require follow-up. How do you follow up?
Stool culture.
Stool culture. Okay, if suppose stool culture is positive and is asymptomatic, what do you do?
Okay, ciprofloxacin.
Ciprofloxacin. Why ciprofloxacin? You can give your ceftriaxone. Eh? Why ciprofloxacin? You all completed NEET and came here. That's why I'm asking this question. From where this bacteria is, where it is harboring and where it is coming out?
Gallbladder.
Gallbladder. Which is the drug which has got a high concentration in gallbladder? Quinolones. Better than your ceftriaxone. They have got a high concentration there. That's why we give quinolone as a prophylaxis. Okay. So what happened to this patient? Is he having any enteric encephalopathy, peritonitis, any other complication he developed? Or
Now he is asymptomatic now.
okay, he is quinolone resistant enteric fever. Quinolone resistant, no? It is resistant, sensitive. So you can de-escalate to quinolones also. That is the most important drug which can prevent further episodes. Okay. Now what happened to his typhoid titer? Vidal repeat came as we didn't send. Okay. Blood culture is enough.
Culture.
Okay. Thank you.